Welcome to Nursing School Explained and this video on phosphorus imbalances. So we'll go over hypo and hyperphosphatemia. And as a quick reference here, normal values of phosphorus in the bloodstream are 2.4 to 4.4. Keep in mind, as always, to check the reference levels for the particular lab that you're working with to make sure that these are the same so that you know if your patient's values are within or not within the normal limits. So phosphorus is a major intracellular electrolyte. So it mostly occurs in the intracellular fluid. It is also important for bones and teeth regulation, and that has to do with it having an inverse relationship to calcium, and we'll get to that in a moment. But phosphorus is also responsible for energy metabolism as an ATP, adenosine triphosphate. So that's a major player here as well. It also helps us in our acid-base buffering system, and then is important for muscle contraction and relaxation to a certain degree, and that always pertains to cardiac, skeletal, and smooth muscle. It doesn't affect the muscles as much as potassium, magnesium, as well as calcium, but because of its inverse relationship with calcium, we have to kind of keep that in the back of our minds. And phosphate levels are regulated by the parathyroid gland, which are 4 small glands that sit on the back of the thyroid gland. And it has, like I already mentioned, an inverse relationship with calcium. And the way that the parathyroid glands regulates our phosphorus as well as calcium levels is if the gland detects that serum calcium levels are low, it'll release parathyroid hormone, PTH, which then will increase the calcium absorption, or it will pull calcium from the bone, and decrease phosphate levels because we know they have this inverse relationship. And then it also it will increase magnesium levels, or magnesium levels usually move in the same direction as calcium levels. And then vice versa, if the parathyroid gland downregulates the release of parathyroid hormone, calcium levels go down, phosphorus levels go up, and magnesium levels go down. So always keep these relationships of these electrolytes in mind, because a lot of them, they kind of work together and they're responsible for, or more than one electrolyte is responsible for certain functions. So for causes of hypophosphatemia, the primary cause is elevated parathyroid hormone, and that is because of primary hyperparathyroidism. So now when the parathyroid gland is overfunctioning, it over-releases that parathyroid hormone, which then increases calcium and decreases phosphate levels, leading to hypophosphatemia. But TP and total parenteral nutrition can also lead to hypophosphatemia, as well as an increased intake in calcium and magnesium, because like we talked over here, they have this inverse relationship. Vomiting and diarrhea, as well as malnutrition and alcohol withdrawal, are other causes of hypophosphatemia. In terms of high phosphorus levels, again, it's regulated by the parathyroid. So if we have low parathyroid hormone, the phosphorus level will go up, as we talked about here earlier. Any kind of increased phosphorus in the diet. And then infants fed cow's milk. So cow's milk is a major source of phosphorus, and the infants just don't have the ability to digest or process it, and then it can lead to hyperphosphatemia, which is not good for infants. Also phosphorus containing laxatives. So think about patients maybe who suffer from chronic constipation or who have some sort of an eating disorder with binging and purging. They're at risk for hyperphosphatemia. And then patients with chronic kidney disease, also patients taken biphosphonates, which are medications that we use in the treatment of osteoporosis. And that has to do with when the patient has osteoporosis, they're lacking calcium. So we're giving them these biphosphonates to help drive the calcium from the serum into the bone to strengthen the bone. But in turn, because of this inverse relationship with calcium, phosphorus levels can go up. And then any kind of decreased intake in calcium and magnesium can lead to increase in phosphorus because of this inverse relationship we talked about here. So then over here, for signs and symptoms of phosphate imbalances, always think muscles and bones. So hypophosphatemia can lead to muscle weakness and decreased deep tendon reflexes, paresthesia such as numbness and tingling, as well as I just discussed osteoporosis and fractures because of the calcium that is increased in the bloodstream because of that. And it can also lead to a decrease in respiratory rate because this muscle weakness can extend to the respiratory muscles and decrease that respiratory rate and drive. And then on the opposite side, for hyperphosphatemia, we have this telltale sign of uremic frost, and that has to do with chronic kidney disease. So watch my video about chronic kidney disease, how that leads to hyperphosphatemia. But uremic frost is this kind of phosphorus that gets deposited in the skin. So when there's too much phosphorus on board, the body will kind of try and deposit it, get rid of it, deposit it in the skin. And many times patients with chronic kidney disease, they kind of have this grayish discoloration that can sometimes even be a little bit flaky. And that is that phosphorus deposited in their skin. And we also refer to it as uremic frost. With hyperphosphatemia, we also need to think about positive Chvostek and Trousseau sign. So look up those signs if you're not familiar. It can lead to an increase in deep tendon reflexes as well as muscle cramps all the way to tetany. And then paresthesia, specifically in the fingers and circummoral, so around the mouth. So because calcium and phosphorus have this inverse relationship, signs and symptoms of hypophosphatemia will coincide with signs and symptoms of hypercalcemia. Vice versa, high phosphorus level signs and symptoms will be the same or very similar to low calcium levels because they have this inverse relationship. So when you're getting confused with deep tendon reflexes, for example, as many times there are many times questions on exams that pertain to that. So just think about, memorize one, and then you can always think about others as well. And the same applies to the deep tendon reflexes, to phosphorus, calcium, as well as magnesium, because magnesium can alter deep tendon reflexes too. So they always move, calcium and magnesium deep tendon reflexes always move in the opposite direction as we have here for phosphorus because of this inverse relationship. Treatment. So if we have low levels of phosphorus, we're going to increase dietary sources, decrease dietary calcium because we know that those work together. And then in severe cases, we can also give the patient IV sodium phosphate. If phosphate levels are too high, we need to decrease the levels on the diet, increase the patient's calcium, maybe put them on diuretics to hopefully get rid of the elevated phosphorus in the bloodstream through the kidneys. And then phosphate binders. So patients specifically again with chronic kidney disease, because we know that there is this risk of this hyperphosphatemia that manifests itself with this uremic frost, they take these phosphate binders to help them bind the phosphate through the GI and then excrete them that way. Nursing care, as always, we want to monitor vital signs because we know it can affect those. We want to monitor their neuromuscular functions, so for paresthesias, numbness and tingling, muscle weaknesses, as well as deep tendon reflexes. We want to put them on a heart monitor because phosphorus in particular doesn't really have any signs and symptoms that are listed here for heart rate or EKG changes, but because it is so closely related to calcium levels, that's always a good idea. We want to check patient's lab, phosphorus, calcium, magnesium, as we talked about. We want to increase weight-bearing exercises in hypophosphatemia, again, because it can lead to osteoporosis all the way to fractures, and weight-bearing exercises will help counteract that. And then we want to closely observe patients' status post-thyroidectomy or any kind of neck surgery to see if something has happened to the parathyroid glands that sit on the back of the thyroid here, and see if we have any imbalances now in parathyroid hormone that can alter our calcium and phosphorus ability to balance those two in the serum. Thanks so much for watching this video on phosphorus imbalances. Please also check out the other videos about the other electrolyte imbalances in my fluid and electrolyte playlist, and I hope to see you soon back right here on Nursing School Explained. Thanks for watching.